A very good afternoon and a very warm welcome to this J&J session. And this is a new concept in AIOS, video-assisted surgical training, so deferred life surgeries. So to begin with, we have Dr. Rohit Shetty, and he'll be showcasing the biconvex lenticule, the shape matters. So essentially, the ELITA on the J&J platform. So all to you, Dr. Rohit Shetty.
Thank you, sir. I realize that there are two talks on the similar subject, so this is a little longer video which has everything. So I'll just try to see if I can. This was done for a deferred life surgery at ESCRS. So I can just forward a little bit because I think Dr. Maipali sir is also showing.
For a part of a trial, where we demonstrated that we need to do a small nomogram adjustment in our geographical population. And we can use whatever nomogram you want here so that this will help in the final correction. There are your K readings here. This interface is something which I really enjoy. You know, it's beautiful. It has that the finesse of a beautiful refractive procedure. The refractive lenticule has a zone of 6 millimeters, transition zone of 8. It has an incision which is around 3 millimeters out here, and it gives you all the other data, the data of depth, the side cut angle. But what I want you to focus on here is the shape of the lenticule. For example, the shape of this lenticule is biconvex. It's very important because it's biconvex. When you have to understand this biconvex nature of the lenticule when you're actually dissecting it, which I'm going to demonstrate as we move on. Dear friends, now let's start with this procedure. Let's call our patient. Let's see how J&J has given us this new machine and how it can help us to bring the lenticule out just like self. How do we make the space? You pinch the clip.
I'll just
like
forward
this.
it a little bit. I think
connect the suction apparatus. Then the patient interface cone is rotated and placed in the socket. We need to look at the PI scan, which scan 360 degrees of the interface to look for any submicron deficiencies which might hinder the suction and subsequent laser from creating a flap or a lenticule. This is a suction apparatus as we described and what goes into your cornea. And this is where I hold it in between my thumb and an index finger. It's important here that I place it gently, and when I place it here, I'm watching for scleral show and whether or not it's equal on all sides. This looks very good. So I ask to press the vacuum, suction on, and suction is on, and then the vacuum is achieved. Now I hold gently and move the bed to the area where the laser will be fired. Sometimes at this point of time, if I see a lot of dry spot, I use this sponge with a little bit of fluid so that there are no dry spots. During this procedure, I gently bring down the patient interface cone. I'm looking at this image here. I'm also looking at where my hand is holding the suction ring. And I make sure my hands are steady, not tilted, and in parallel. I don't tilt the suction apparatus, and now the PI cone is gently touching. At this point of time, I look at the PI, and now the step is very important. This is the space with the vertical height. I move the knob slowly, gently, till I reach the green zone. Again ensuring I'm still in the green zone. Then I pinch the ring to allow the patient interface to come in contact with the cornea. And then I leave it, and making sure the meniscus is not in the area of the laser and I push the meniscus as far away as possible. Here, I can adjust the position and ensure centration on the pupil center. We have also shown the fellow eye here where we need to do a cyclotorsion compensation as well, which is much highlighted feature on this machine. So you can see the raster pattern of the laser being fired here, which hardly takes close to 17 odd seconds. We can see how the minimal spot to spot makes this possible and gives a smoother cut. Now it's making the incision. What we have here is a 3D reconstruction of the lenticular shape in silk procedure compared to other comparative technologies. It shows us how the anterior-posterior orientation is biconvex. This is confirmed on OCT images as well. Keeping in mind this biconvex nature of the lenticule, we enter the anterior plane more acutely at the 12 o'clock position, similar to how you would kick a football. So we open up the incision like this and dissect 2 to 3 millimeters of the anterior plane like a wiper blade. After I do that, I enter the posterior plane, and the way to do it is to enter 3 to 4 millimeter away from the central entry like this and dissect in a similar way. Then the anterior plane is dissected in a windshield wiper motion. Subsequently, the posterior plane is dissected, keeping in mind that one needs to enter to the same side where the posterior plane has been opened. Dissection at 3 and 9 o'clock should be left for smooth-like procedure.
Thank you.
Thank you, Dr. Rohit, for that wonderful presentation. And I think that covers the entire gamut of lenticle extraction on this wonderful ELITA platform. So I think three major advantages that you've given is the shape, the biconvex, which essentially transforms into less dryness. And I think the depth also, in your studies, you mentioned that there is some element of the spherical aberrations or maybe the depth which is enhanced in comparison. So quick word, what essentially, does this mean that when we are looking at refractive correction after the age of 40, and could it be a new arena for presbyopic kind of a...
Absolutely, sir. So you were there at the lenticule meeting. There was a big discussion about every lenticule after the applanation is taken out is a biconvex design. Of course, some way you may debate, that's a different ballgame altogether. But we didn't have time to discuss is when you do a modeling work, when you take out a biconvex shape design, there is some amount of pressure put from both the posterior part of the cornea and from the anterior. When you dissect something which is more physiological in nature, that means both anterior and posterior curvature are matched, then your amount of pressure which is put on the top and below, there is difference in different type of lenticule. That's a modeling work being done, which is already published, and some of them it's in on way. So that means when it matches with the more physiological shape, when you have pressure from both below and anterior and posterior, your cornea Young's modulus behaves completely differently. That has an impact on the pre or post-operative shape, and that is why you get less SA, more balanced sphericity, and of course, like you rightly said, definitely gives you a small EDOF-like picture on the cornea.
I had a question, Rohit. Since you've been a pioneer of Smile as well, and then now you've been, done actually the trials and you've been using it, what do you see as the big advantage of Smile over this, or Elita over Smile? Like, which are those few points? Like, I know that you always have an objective.
See, the
view.
big advantage I feel is, I'm sure all companies will also move towards different shapes. Is the shape, We, at this point of time, I think there are two other work done by, say, Rushad and other people also suggest that the shape has a huge impact in how the cornea remodels itself, both mathematically and also, that is, I think, a big thing. And by creating a shape which is bypassing a lot of nerve bundles, there's a definite faster regeneration. So I think if these are the two things, and this has a huge role that in future, this keeps your sphericity minimally changed. That has an advantage when you look at it from a post-cataract and these patients, or the depth of focus may not be a great thing when you're 25, but when you turn 30, that's when you start stenopic symptoms set in. You feel tired, you feel headache, and all those things. So that has a huge role.
So we have our next surgeon now, Dr. Gaurav Luthra. We all know he's a prolific surgeon, excellent surgeon. He'll be showing his video on flex-assisted next-generation monofocal toric for the best possible visual outcomes. So this is something as the monofocal plus lenses. Oh, no, you're talking about the monofocal. Okay, please, carry on.
Thanks a lot, Dr. Ajay. And this is an interesting format. May not be as dramatic as live surgery. Oh.
So since we are in the J&J session, by the time Gaurav takes, a quick question to all of you. How many of you have been now shifting from the standard monofocal to the advanced monofocal, the iHands IOLs? Any take on how many people are now using the iHands and feel satisfied? So, I mean, what is the advantage in your practice that you feel has really given you from the single piece to the iHands? Can we have a mic, please, fast?
PPT नहीं है मेरा वीडियो है.
Bits are very less, and so this lens suits 80 to 90% of their day-to-day work. So it's really helpful. They are quite satisfied.
And plus, there are no dysphototic symptoms, so that the patient doesn't have any glare halo when they are actively driving.
Yes, sir. The driving is they're very comfortable, particularly evening 4 to 6, where they drive back home. They're very comfortable.
Are you ready, Gaurav?
Yes.
Yeah. Sorry. Yeah. All to you, Gaurav.
Okay, thanks. So this was a young gentleman, 39 years old. He was an IT guy and had been diagnosed as a diabetic about a few years back and had no diabetic retinopathy, but he was very keen to get good distance and intermediate vision if possible. And also fond of driving at night, so we had a discussion and he decided that he didn't want any of the IOLs with the rings. So looking at that, we decided to go ahead with his cataract surgery. he was basically diagnosed as a pre-senile cataract. Everything else looked good. The fovea was healthy. Biometry showed an astigmatism. As you can see here, we were doing the left eye first, and it was showing IOL. So I like to use, even if there's like this patient has a 0.5 astigmatism, but it's showing a lens which is 100 model on the J&J platform or the T2 on the Alcon platform. So I would want to use that for correcting even those small astigmatisms, and so we decided to go with the toric lens. This is on the anterior and the eye trace. We like to do 4 devices for our toric measurements. It helps us get the right thing. So the surgery was planned, and as you can see that on the catalyst which we use now, it also has the toric marks which can be put on the cornea, and of late with the new software version they will have the toric marking on the cornea based on the IOLMaster 700 cyclotorsion control. So you can actually transfer data from the IOLMaster 700 onto the catalyst, and that will give iris recognition or limbal recognition and give you the exact toric marking as well. And based on that, then you can go ahead with your planning. So here we did this toric planning, and of course we will later on use a Callisto, but these marks are good because even post-operatively, in the long term, if you're looking for any kind of rotation of the toric IOL, you can just dilate and see whether the toric marks on the IOL coincide with these marks on the cornea, which will remain visible, even post-operatively for many, many years. So now once these marks are, we've gone through the whole plan of 5 millimeter excess, and these are the, it leaves about 20% of depth anteriorly and 20% posteriorly, and then you have these toric marks which are basically intrastromal marks. So that's the whole plan, and then we decide to go ahead with the surgery. And the Catalyst, I've been using it for 5-7 years now, and it's an excellent machine. And these patients where you're doing premium IOLs or even complex cataracts like RKIs or posterior polars and black cataracts and subluxated cataracts, I always prefer to use a femto-assisted surgery as well. And patients, do well. Small eyes, high hyperopic eyes, small anterior chamber depths. So a little fast forwarded here to manage within the time provided. And that's the pack which goes in, and then you can use the suction. And as compared to other platforms here, because there's a fluid interface, the quality of the rexes and other things is excellent. And I think most of the people sitting on the podium are all Catalyst users, so they will concur that the Catalyst has been a beautiful platform. Now once you've centered it, and it's very intuitive, you can go through the steps within seconds, and takes barely 3-4 minutes to complete one patient's surgery. This is the OCT which is now scanning, and then you align the cone, and then you have the landmarks, and then you can check your rexes is in order, then the posterior capsule offset, and then your toric marks. And once you've gone through those, then you are ready to fire. And capsulotomy is over in less than a second. That's why I love it even for my intumescent cataracts, because the risk of getting an Argentinian flag sign is almost not there. And then you can do these toric marks. As you can see, they're happening on the cornea. So you have all this over in less than a minute. And then you can, of course, move into the other room. So a drop of betadine at this point. And so here I use the Artivo system for my surgeries, which is a heads-up display. And here you can see the Callisto marks as well, and then I put a manual mark. So most often the Callisto mark will coincide with the what you got on the femto LRI, but with the IOLMaster 700 link up, things become much easier. So this is a heads-up display, as you can see, and gives a lot of control, and you can operate on very, very low illuminations. So the 3D display is quite remarkable with a very big screen. And that's the inside display from the surgeon's perspective. So the rexus is usually 99% of the times free-floating, except in maybe very fibrotic cataracts or occasional intumescent cataracts where you'll have to just complete it a little bit, and a good hydrodissection, and then routine steps of cataract surgery. This would not be a hard cataract really, because the patient is only about 40 years old. I would have wanted to show you the Veritas, which we have been using now for a couple of weeks, but somehow the heads-up display on the Veritas was not yet set up for us. But we have been really enjoying the new Veritas, which is a new launch from the J&J. So there are those cracks. This is a softish cataract, but still those cracks help because now it's much easier for you to ensure that you don't have to go for one of the other soft nucleus techniques. So you can just engage them and they're out in a jiffy. So the depth of focus and everything is so much more enhanced when you're doing the Artivo system, as you can see on the left side where I'm seeing from on the screen. This gives you much better depth as what you can see through the microscope, and patient comfort is much better. So once the lens is out, you can go ahead with the cortex. I like to use bimanual IA. And these are calibrated instruments. I like to use 22 gauge pre-calibrated knives along with that 22 gauge bimanual, so there's almost no fluid loss. And as you can see, we are operating on an IOP of 26 and chamber stability remains excellent. I like to use even on the Signature Pro, on the Veritas, I'm using a bottle height of just about 40, which translates to a 29 IOP. And these new machines are all amazing. They have great fluidics. Especially with the new pack which has come up on the Veritas, you can have excellent chamber stability. So your rexis is well centered and perfect as demands from the IOLs. I like to do a hydroimplantation, and here you can see that this is the iHands toric. This has been a wonderful lens, and I've been so happy ever since the toric platform was available, because initially iHands used to come as a non-toric. I end up using almost 70% of my cases get a toric lens for correction of astigmatism, even which is when it's very small, and centers beautifully. And the Toric 2 platform, which has the frosted haptics on the iHands, is amazing, because even rotating it inside the bag sometimes becomes challenging, because they have a good kind of resistance to rotation. So the chances of getting poor rotation is much less. Here on the AIOCT, you can see that we are hydrating the wounds, and you can actually see that the wounds settle well, and that's the positioning of the IOL. So the EDOF, the iHands monofocal iHands platform from J&J, which I've been using for last few years, has given excellent results for people who need good intermediate vision and great distance vision with the lowest risk of postoperative halos and glare. This lens works beautifully well, and the ad which generally that we've required is just about 1.25 to 1.5, and many patients actually opt not to make their reading glasses at all, because most of their needs are met. So that's the OCT to show you that the incision is nicely sealed. And with that, I'll stop here. Thank you.
So congratulations, Gaurav. An excellent surgery. I think the effective lens position, the well-centered rexis, and the rightly positioned toric iHands, I think boils down essentially to what is, a modern-day cataract or a refractive surgery that we actually say. So I think all in all, Johnson with their, the Catalyst laser platform, the phaco machine systems that they have, and the implants that they have in the basket, I think it's a total transformation of the cataract surgery that we have been seeing over the past.
Also, I wanted to add, Sonu, that all these patients where you had to think like 10 times before implanting a lens, which gave some kind of intermediate ability, like some for some reason macula is not very healthy, or you have a small corneal opacity, post-refractive surgery patients, and patients who otherwise are not eligible for a multifocal platform, and now you can easily offer them. And I've been doing a lot of RK patients and other patients where I would happily use this and get great results. And I'm sure Dr. Ajay has. What are your views on the monofocal plus? So what's your take?
It's excellent lens, and ever since it has come, probably my practice, it has shifted to 80% from the monofocal lenses to monofocal plus. And getting a toric also along with the monofocal plus is a boon, because like Dr. Gaurav said, astigmatism should be corrected, and in my practice, what we start is somewhere between 0.75 onwards. So this is excellent lens what we have.
So I think it's a very forgiving lens in terms of the macular and the glaucomatous or the optic nerve conditions and the corneal conditions are concerned. So all in all, I think, it's a complete transformation from monofocal to the modified. Yes, sir. A quick question, and then you can.
Okay. I think he wants to speak first. He's saying मेरे को कर
उधर एंडोमेंट में तो लाल question?
Yes, sir, please. Yes.
Wonderful presentation, as always. I just had a question that how would you're talking about the J&J platform, that's fine. So how do you compare this to a Vivity, say, from Alcon? And my experience with diabetic, even post-maculopathy, settle down. I think a lot of them, if you're giving them monofocal and this, I think it's a better thing because they get that intermediate ability. So that's my feel from what I have seen. And so what's your take on it?
Absolutely. So, in fact, most of my monofocal practice has got converted into a monofocal plus kind of a lens like the iHands. So, it's only those who may not afford for some reason, otherwise most people can. But yes, you're absolutely right that while if you asked whether how it compares to the Vivity now, I have been using the Vivity a bit as well. Vivity gives you slightly better intermediate vision than, in the group of the iHands group of lenses. But there is also that patient occasionally who will have, some kind of a funny, distance vision deficit which they will not be able to explain. And you would have some patients who will not be a crisp 6x6 even with best correction, and you'll have them like 6.9 or 6.12. So for some reason, because it gives you a little extra kind of depth of focus than the iHands, it might give you slightly better intermediate vision, but then it may compromise and also occasional patients with glare and halos on the Vivity platform. So it's a great lens, and I've had some very happy patients with the Vivity, but I think few times before I put the Vivity, whereas with the iHands, I don't think much about it. Almost all patients will do well.
Thank you, Dr. Gaurav. I'll be showing...
Thanks, Dr. Maipal, sir, for sparing time and coming for this session.
I've just across. Can you give me video? I'll be showing you deferred lenticule extraction. That is called as the smooth incision lenticular keratomelusis, or the silk procedure. And can we have the parameters on the screen, please? A young, beautiful girl, she's age? So these are the parameters. She's 24 years old, and we have fed this. These are the parameters that you can see. On the parameters, you can see that there is a slight nomogram adjustment that we have. So it is 4 diopters, which we have made it into 4.25. That's a slight overcorrection with the nomogram settings that we have, and a cylinder of 0.25. So this is the sphere adjustment and the cylinder adjustment that we have done. So from 4.25, we have done a sphere adjustment of 0.68. In this particular case, and a cylinder adjustment of 0.03. So the ultimate correction that we are going to do is minus 4.93 and 0.28 in the... So just to tell you that there is a nomogram adjustment that has been done when we started the clinical trials in January 2020. The results, we were getting slight undercorrection. So to overcome that, there has been a nomogram adjustment, and this nomogram adjustment for the sphere is we add minus 0.25 and 5% of the refractive error as regards the sphere. The second nomogram adjustment that came in was for higher myopias also. We just increased a little more, as also for the cylinder. So that is what I am talking, that these are the adjustments. That means that instead of 4.25, we added 0.68 and 0.03 because the cylinder is very small, which is only 0.25. So this is the nomogram adjustment that has been done. In the cylinder, the keratometry is 44.6 and 45.5. You can see here that including the optic zone is 6 millimeter, and the total zone for which the laser is going to fire is 7.6 millimeters. And this is the entry cut, which is 3 millimeters that we have. You can see that this is a biconvex, this is a biconvex lenticule shape which is there with a side cut angle of 60 degrees. The residual bed thickness comes, which is 325 microns. Total thickness is 88 microns. So this also, like the Visumax system, for those who have worked, has a flat ad. That means that there is, if you have thinner cornea, thinner lenticule, then you can add a flat ad which can be from 10 microns to 30 microns. So which does not cause any refractive change. So that is what you can add. And this flat ad is within the biconvex lenticule. It is not on the top of the lenticule. So this flat ad, you have to have minimum of 10 microns. That is there. That is part of the machine. So this is what I was telling about the flat ad. And you can see that the depth at which we are making the cap is 110 microns. So this is the settings that we have. So you can see here, this is the 0180. I'll just mark it a little more.
So this has to be marked in the OPD. We're just making it a little more. There's a manual
Okay.
cyclotorsion that is there, as also a manual centration which is there in this particular
Now
case.
we
that you
ask
have
the
to do.
patient to kind of look. So we have to track the visual axis. Bete light mein dekhna. With one eye, we have marked the center. You can see that's the center mark that we have done.
So this is the visual axis that is being marked.
Once
So
the
therefore
center
the
mark has
lenticle
been
will
done,
be on
we
the
are
visual
ready
axis.
because this will help us because it's a tight dock, so it will help us in also centering on the visual axis. So you can see that's the visual axis. Now let's go on to the PI. You can see that this is the interface that we have. Open it.
This is a single-use
So
patient
this
interface.
consists of two pieces. Nikal. So we'll just take out the first piece. This is what goes onto the eye, and this is what goes on to the undersurface. You can see this goes on. They have lashed it onto the undersurface, and once it is lashed, you will put these into the suction. Either.
So I think within the end of this year, hopefully
This
it
is
will
being
become a
put
single-piece
into the
patient
suction
interface.
that's on the machine.
Just now it is two pieces.
Yeah,
We'll get a
and then
single piece.
Approve the readings that I had shown you. And you can see that this is the scanning of the PI. So every PI first, before we actually go ahead and do the laser. So this is completed. And now,
So the PI scan is actually for giving you whether there is any tilt or there is any difference in the thickness of the patient interface, right? So if it is, then it will be rejected and you cannot move forward, okay? So this is an auto test that the machine does.
we
So
can
there is that red blinking
just
light.
go on and
Patient
proceed.
will be looking into it.
Cornea.
Always moisten the cornea
So,
slightly
बेटे, अभी आपको
because
सीधे
otherwise
देखना है,
you can get
would
dry
want to
spots
moisten
on the
cornea a little bit.
laser.
And light one, light. सीधा देखो बेटे light में. So this is the suction ring. You can see we are placing it at 180, suction on. So suction is on. Low. Bed.
This is
We
the
bring
red
the
blinking
bed
light that the patient sees.
Below.
The bed can be moved up as
Once
also
we
the
have
machine
brought the
can come
bed
down.
down, now we will bring down the alignment, the PI onto the so you can see we are bringing down ऊपर कर maximum करना. Okay, so we'll go down. You can see that the patient interface is getting docked. This is as we go in. ऊपर कर.
So now you come in the green zone. This is important that you are in the green zone. This
You
shows
can
that
see
your
this.
pressure is adequate.
Okay.
You pinching the thing, if you can
So you
watch
can
here,
see
you are
this is
pinching the
the
grabber
perfect
and
dock that we have.
this is more
Now
than 10
we have to
millimeters.
do
Can you
the-
see this white ring? It is beyond the white
So
ring,
we
10
have to remain
millimeters.
in the green part. You can see there is a docking which is about 40 to 50. We keep it on the green. Now you can see that there is a minute cyclotorsion adjustment which we will do. First the centration. You can see we are bringing on the onto the center where we had marked. Okay, this is the cyclotorsion adjustment, which is 4 degrees, which has been done, though it's only a 0.25 cylinder. We are ready now for the treatment. Bete hilna nahi ab.
So now the foot comes.
Machine is set now. Estimated time 16.6 seconds, and this is the laser that is being fired. This is the posterior part of the lenticule that is fired. This is the side cut. You can see how fast this laser is. It is showing 52% amount of time remaining. This is the anterior cut, and you can see that this is the entry cut that has been made. So once this is done, you can see that's the end of it, and the machine will auto undock, and it will just get raised. We can bring it back. We can bring the machine back onto the
So there's a microscope. The machine
Now you
doesn't
can
come
see
with a
this is
microscope.
the-
You have to use your own
बेटे लाइट में
microscope.
देखना. This is the lenticule that has been created. You can see the eye looks pretty quiet. सीधा देखिएगा. लाइट को देखो आप बेटे. The entry cut, as you saw, went over several times. So this is the most easy to enter. Now what we have to do is that we have to go upwards because it's hilana nahi bete, because it's a biconvex lenticule. So you can see this just going upwards there. Okay. On
That's
one side,
anterior
now
to the
we go
lenticule.
posteriorly.
That's posterior to the lenticule.
Cornea.
You can see these are two separate planes that have been
Having
identified.
identified both the planes, सीधा देखो बेटे, लाइट को देखो, लाइट को.
I use a blunt spatula and I don't use a holding forceps because sometimes patient feels pain and the patient
So you
can
can
tear
see
it.
here that there is hardly any dissection that we have to do. It's like going through a knife going through warm butter. सीधा देखिए लाइट को. And again we go into the posterior. Again you can see that the mark is not coming into the way of the separation which you could see. And as we go, you can see very little dissection is required. There is a separation that we do from one side first and then go on to the cornea, then go on to the other side. And this you can see is the finishing of the dissection. You could see that there is hardly anything that was required onto the dissection. So you can see that.
So that's
You
the
can see
lenticule
that
being
full
taken out.
lenticule, no problem. मेरे
You
को
can
देना.
spread the
Spread
lenticule
करने
and
के लिए.
see that it is
The
complete.
complete lenticule that you get out. And separation,
So
because
that's-
this is 1 micron and no spot and line separation.
So
Therefore,
I'll
almost
just, so that is the end of the procedure. The important thing in this machine is that you can do a centration on the visual axis. You can do a cyclotorsion. The spot size is about 1.3 microns. Each spot, there is no spot separation and there is no line separation. And because of that, you get almost zero dissection or minimal dissection. So 90% of the times the surgeon felt that there is almost zero or minimal dissection that is required. There hasn't been any instance with us. Now there are about 25 units that are installed in the world of suction loss because the suction is pretty tight. People often ask a question, how much? So it's about 50 millimeters of mercury that the pressure goes up to. And what else? Dissection is very little that is there. Biomicroscopy on day one, you get clear corneas, and we have got within plus minus 0.5 which has been published. This is our study and NN study, and then Croatia, and then Singapore. So that we have got is more than 92% of the cases, and the visual recovery is pretty good. So now this machine is commercially available. We were happy to be involved with the first procedure that was done for the flap. This machine today has a flap and it has a lenticule. So the first flap procedure was done in December 2018. The first lenticule was done on 5th or 3rd of January 2020. So it's been 4 years plus since we have been working, and now it's available. I think Ajay is using this machine also and I think there are about 8 installations of this particular machine in India. Thank you very much for seeing this particular video. Thank you.
Thank you, sir, for bringing that overview of the silk procedure. And I think that biconvex lenticule again has its own advantages.
Yeah, so biconvex, there are 2-3 advantages. The first advantage is that because it's biconvex and not plano-convex, the nerves don't get transacted right at the plano-convex. So it's like going this. So the Rohit's group has shown that the dry eye is still lower as silk as compared to smile. The second thing is that he has shown also on confocal microscopy the nerve regeneration being faster. The other thing is that the induction of abrasions, whether it be spherical abrasions or higher order abrasions, is minimized because biconvex lenticule is the shape that all, say, a good camera lens, for example, would be a biconvex lens and it will not be a plano-convex. The other thing is because it's biconvex, it has been shown that in smile or in silk, whatever in the lenticule, there are ridges in the Bowman's membrane which has been reported by the Chinese, which takes a little while to go. That is why the clarity clarity of vision may take a little longer. That's what was thought earlier. So here, the biconvex shape, the thing fits in better. And again, this is NN's work that they are showing that the Bowman's has less undulations in the silk procedure. But in any case, I think lenticule is the way to go. We have been on the lenticule for more than 10 years, and our group, Rupal, was the first person to do the silk procedure, the way the smile procedure, the way it is being done in the world. And we were happy to be part of this trial and now have the approvals.
So what about cyclotorsion control? Like just like on the Catalyst, they have now linked it with the 700.
Yeah, they are going to link it to the IOL Master 700. They are also looking at, we have put it as the lower priority. The two priorities, that is what I have said is that I need the ammunition in my arm to do a spot and a line separation. A spot and a line separation is allowing us, or just a spot separation, 1.3 spot separation of 2 microns has reduced the quantum of energy going into the cornea by another 48%. So that is my first, because see, when the basic thing in a femto is a bubble hit, it expands. So you're not giving any space for the bubble to expand because it's superimposing on each. So that is what my first priority is. Second is a single piece PI. Third is hyperopic correction. Fourth is linking this to IOL Master or to the eye design. And they are looking at wavefront treatment also with this, but that's, I think, will be taking a little longer. But yes, IOL Master 700 just now has been linked to the Catalyst, so I think they can link the thing. So possibly they'll be able to link it, but the linking has also been done with the eye design on the custom view. So their engineers have the propensity to link. So I think that linking will help you in the torsional correction of it.
What about astigmatic corrections? Like, are you, because
I have done up to -5 diopters flat. Like,
do you see it doing much better than what you were doing with the Visumax?
I was a little apprehensive earlier, but because there is a cyclotorsion alignment, I am getting good results. I have got 20/20 with a 0.25 remaining in a -3 with -3.75 SIL. So the results are pretty good. I don't have any apprehension in doing a cylindrical correction in this.
Thank you,
Thank
sir.
you.
Thank you, sir.
Thank you very much for an excellent talk. Now we have Dr. Sonu Goyal. We all know he is amongst the top surgeons in India and Rajasthan. He comes from Jaipur. He'll be talking on phaco with CRV IOL toric, builds trust in all light conditions.
ऑडियो जैक लगा दिया. So at the outset, I'd like to thank AIOS, Dr. Namrata Sharma, and J&J for giving me this opportunity for the deferred light surgery, a good concept for teaching. And so all in all, I believe the J&J with their entire spectrum of lenses that they have has actually made our life very easy. And with the modified monofocal IOLs replacing most of our monofocal practices, and the trifocals replacing essentially all our multifocal practices, have actually promised our patients much more than we used to deliver. So hi, a very warm welcome for this deferred light surgery session for the AIOS. So essentially, this patient that we recently did, we did a live recording for this 56-year-old bureaucrat, and so his, he wants to spend most of his time on mobile. He's an avid desktop because most of his office work is on desktop. He plays golf, though he's an occasional driver. So quick parameters here, but what is more important is the IL power is 21.5 with a cylinder of -1.59 at 79. So routinely in all our cataract case patients, we do routine all anterior segment and posterior segment examinations, including the eye trace, the specular, the fundus, pressures, and the dry eye assessment on the lippy view. So this is what the IOL Master speaks. So this is the toric sheet on the Barrett's calculator, and the specular where the cell count looks quite good. This is the lippy view where the LLP was around 77. So patients where we find a borderline dry eye, we usually take these patients for dry eye treatment, treat the ocular surface, do again an ILMaster scan, and then take them for cataract surgery. Routine OCT for all these premium patients, because subtle macular lesions can then be picked up when you're actually treating. So this device on these eyes has helped us to give a peripheral examination. So this is how the toric calculation sheet, once you order the patient, sent to the Johnson & Johnson, they would give you. So essentially we have the toric lens here. The model is ZF W300, and the orientation has to be 170 degrees. So I go in, take this patient, and so a very good afternoon. And today we have this 60-year-old gentleman, and he's a bureaucrat by profession. And so I don't use toric marker. I just use the manual marking here, just to showcase that essentially fancy gadgets, if you have, yes, but still toric patients can be used. So pre-op marking has been done. I essentially use 2 side port incisions. Viscoelastic HPMC is routine to be used. I think capsulorhexis is one very important step whenever you're dealing with these premium patients, because essentially the rhexis has to be 5.1, because you actually want that shrink wrap effect. This has to be well centered, and yes, this is actually what gives you the effective lens position, because once you're dealing, you're taking these patients with ILMaster 700, you're going as close to 0.025 with your target residual refractive error. So your surgery has to be spick and span to actually deliver that kind of refractive correction in cataract surgery when you're dealing with these premium patients. So a good capsulorhexis, very carefully, I fashion a 5.1 capsulorhexis. So I'll be using the J&J platform. I use a Signature Pro here, and I think Signature Pro has really helped me, because it works both on the peristaltic and the Venturi platform. So actually on the go, you can shift between the 2 modes just on the fly. And most of my aspiration part I would do on the Venturi, because it makes my life easy. When you have a long list, I think the workflow becomes very easy. So once the rhexis has been done, the main port incision has been designed. I usually do not dial the nucleus, so I would just push in a fluid wave, and this is actually gives me an idea that 360 degrees I have separated the nucleus from the cortical matter. So I do not stress my zonules, and I would not like to dial unless and until I feel that the wave has not been fully observed. Viscoelastic goes in and push in my phaco handpiece. The settings are, so bottle height we have gradually shifted. So though it's a gravity-based system, and we have shifted the bottle height from almost 90 centimeters to close to 50 to 60 centimeters, and that has actually given a very stable anterior chamber along with minimal stress, minimal intraocular pressure, and actually saves the endothelium and saves the optic nerve in borderline glaucoma patients. So I go in, push in, just hold. It's a very soft nucleus, so hardly any chop required. A gentle hold and then chop. Most of the times I would like to share with the beginners here, I usually deter from moving my right hand most of the time. So the right hand would remain stable right in the center, and it is most of the times that the left hand would move and rotate and chop and separate the nucleus most of the times. So this is how I am trying to emulsify, break it into 4 fragments, and paucity of time, I would just like to show the bottle height here. It's close to 50. So vacuum, I'm using around 300. The aspiration flow is around 32 with the power of around 25. So this is how very carefully phacoemulsification being carried out. And then the irrigation aspiration, I use the bimanual here. Bimanual is very important once you're doing topical surgery, and it gives you a good hold on the eye and gives a 360-degree sweep all around. You can actually take away all the lens matter, subincisional as well. And if you have these sandblasted, at the same time, you can polish the posterior capsule. So routinely in my patients, I would always clear the visual axis. I will try to polish. So there are multiple ways. You can just push in a jet of fluid onto the posterior capsule. You can use those sandblasted instruments to actually polish. And if it's not a toric, I would also like to do away with the undersurface of the anterior capsule and try to clean off that area. So this is how very carefully I'm trying to remove the lens matter all 360 degrees, and this is the polishing system that we use. This is a sandblasted. I snugly go on to the this is the irrigation device. So I go, this is the polishing device. This is sandblasted and has a fluid coming from top. I go snugly onto the posterior capsule, wash away the viscoelastic, wash away the lens matter. I push in the viscoelastic here, and the lens that I'm using here is a Synergy toric. So this is how the lens, it's built in on the single piece platform. This is a hydrophobic lens, and you see the 15 ring segments. So the beauty of this system is that they have combined their multifocal, the J&J multifocal platform along with the Symphony. So they're combining two technologies, essentially transformed to a CRV lens, which is a continuous range of vision IOL. So multifocal was giving you a very crisp distance and a crisp near. So this is the injector device system. It can be a shooter or a screw, but screw gives me quite a good control. So most of the times I would use a screw device and very slowly holding and supporting the globe with either a Sinsky or a McPherson on the left side. I would just try and slowly screw the lens inside the bag, and most of the times lens essentially unfolds within the bag. So talking about this lens, it's a beautiful combination of their multifocal and the Symphony lens, which was earlier the extended range of vision IOL. So combining these technologies has actually given you a continuous range of vision. And what is more important is that the patient usually does not complain of the dysphotoptic symptoms, I think, and the contrast has been really great with these lenses. The only possible reason that they've given is that it is a violet light filtering lens, and actually gives you more of the blue light, and the violet, which is a nuisance and causes more of the dysphotoptic symptoms during the night driving, is cut off. So I think that actually transforms into a good quality of vision, and vision in low contrast and better color perceptions. So I would slightly dial and orient the lens to 170 degrees, and I wash the viscoelastic from the posterior surface. So for all these toric IOLs, 3 quick steps, and I think with the type 2 kind of system, the haptics being sandblasted, I think that gives you a rotational stability. So washing viscoelastic from behind, tapping the lens slightly onto the anterior surface, and never overfilling or overhydrating the anterior chamber, I think that actually gives you a very stable toric platform on day one.
So I think we'll have to move on. The session is almost over.
So just that finishes most of the surgery, and this is how the day one picture looks like, and the patient has a very crisp distance, intermediate and near. So I think most of the practice has really shifted to either the advanced monofocals, or for patient desirous of getting glass free, I think these trifocal lenses or the CRV lenses work very well. Thank you very much.
It's a beautiful demonstration, and of course you've kind of left nothing for us to discuss. You've told almost everything. That is, so we'll move on to the last talk for today, and by Dr. Ajay Sharma, who's one of the most renowned cataract surgeons practicing in Gurgaon of the IQ group, and he will be speaking to us on flax with the CRV toric IOL for continuous range of vision from 33 centimeters and beyond. So Dr. Ajay, please go ahead.
Thank you, Gaurav. Thank you, AIS, for having me here. So I'll be showing you a recorded live surgery of patient. These are the parameters: 74-year male, diabetic, K1, K2. You can see a cylinder of 1.98 diopters, and this is the toric sheet, and here, the oil master here, where I just want to show that the lens chosen here is 25.5 diopters, which is towards hyperopic, not on the myopic side, normally what we usually do with other lenses, and because this is a Synergy toric lens I'm implanting. This is the toric sheet calculator, and here we see the placement is in 170 degree. These will be my settings, where I'll be having a vacuum of 500 and power for 40 and aspiration rate of 36. This is a pre-recorded video. the marking here is very important. Just before you start, we need to have the patient marked properly, and we put a speculum after putting Paracaine, and the patient is marked here inside the OT before we start. This is a bubble marker, and then we take the patient. I'm showing a flex here, so not a phaco, and we will be doing a flex surgery here. Now this is the cone. The LOI here, it has 2 components, and you can see how the cone is being fixed. And now you can see the integral scan being done. The surface mapping is being done, and the anterior posterior surface, the lens and all can be seen properly. Now this capsulotomy here, it says the pupil is not wide enough, so we give an option of pupil maximized. And these are the marks for the toric marks which I want to show, and in just 40 seconds the surgery is done, though it is a grade 4 type of a cataract. And so here what we decided to have these mesh type of softening, where Dr. Gaurav showed was just the incision, the 5 incision there, but here we are giving the softening also. And important part is this where you will see the marks for the toric. Now this is at 170 degree, and this is what I want to show is this marking will be at 170 degree, very nicely visible here also, and even on table. And now this is done. Sorry for that. And this will be, now this is the marking. You can see these 2 marks. Now this is done, and then we shift the patient to the OR. Here we can see very hard lens. Free floating capsular axis can be seen. Now this is the beauty of the catalyst machine what we have. The marks have already been done, but the 2 marks which were given by the catalysts are there. So you can, I don't know whether it will be visible here on the video, but it's properly visible to me on the operating table. The incisions again have to be very important. We try to make a triplanar ones, but definitely need to be a biplanar. You go in and then you deep down and look here. So this is what we try to do. And you see the bubbles here because after the flex surgery, when you do this softening of the lens, that honeycomb appearance what you see, there are these bubbles. You just burp the lens and the bubbles will come out. Initially for the rexus, we used to put some visco and then take it out, but now we directly do a hydro, and then this we put some visco before starting the phaco. Now since it is a grade 4 phaco, we will be on the parameters of the chopping here with the 500 vacuum and 40 energy. And so this is, now it is pre-cut, but definitely because it is a very hard lens, it will need some energy here. But overall energy is reduced in doing these cases because with the flex, and that is what we need to know. And so we are trying to divide, and you can see the first divide is we can, so a bit difficult, we rotate it, and then further we want to divide it. So already cut thing, and we just are trying to chop it again. So once one segment is done, it's easy to take the other ones. Now this is done, so we can rotate in. You can see this central hard nucleus here, because whenever in hard cases you have this, even after doing a flex you will find this. And so once this is separated, the things are easy. You can just take the lens out with the phaco. I'll just so this is the final separation, and then the nucleus removal is easy. So one important thing is just the movement of your second hand and the second instrument. Here you see the phaco tip is stable more or less in the center, and it is not being used, only the second instrument is being used. This is very important whenever you're dealing with these hard cans or otherwise also. We move it only when we want to take the segment out. We go towards the segment. So this is done, not much of a IA because the lens was hard and the epicortex has come out along with it. We'll be implanting a Synergy toric IOL. Now, as explained by Dr. Sonu, Synergy toric is an excellent lens which we have from Johnson & Johnson platform. Now, it is a combination of a multifocal lens and a Symphony lens. Symphony gives it a chromaline technology, and it is basically a Technis-based lens, and we all know what Technis lens is. With the Technis 2 toric platform, the stability of this toric lens is excellent. The surfaces are square-edged and they are a bit frosted, so that's the reason the lens, once it is in the position, I'm just rotating it and here it is in the position. So that was the 170. You can see the three dots here, and that is where you connect. You align it with the marks here, and then is just the IA being done. Now, once doing the IA, again, as cited by other surgeons as well, you have to remove the visco from behind the lenses in wherever you can, and because this again will make the lens more stable. Now, this is just to show you alignment. So at 170 degree, the lens is aligned. I'm just checking it on for the final alignment of the lens. Now, once aligned, it is a very stable lens. You don't find any problem with it. I have never seen it being displaced or moved maybe next day or even after weeks. So that's the end of the surgery. Thank you very much.
Excellent surgery, Dr. Ajay, and yes, the lens is quite amazing. I think we'll have to give the hall to the next session because we've already exceeded our times, but thank you for showing a very, very challenging cataract and an excellent surgery. Thanks, Sonu, and thanks to all the speakers and Johnson & Johnson for organizing this session. We hand over to Dr. Anaga, who is going to speak next.